Welcome to the Human Architecture Clinical Theater. In this space, we deconstruct the biocomputational grids that govern human physiology. We strip away macroscopic visual illusions to expose the physical chemistry driving diagnostic reality and acute bedside survival. We focus today on phosphate, or inorganic phosphorus. This chemical makes up 1% of total body weight and is the structural and energetic foundation of human cellular machinery. Treating macroscopic failure requires understanding the microscopic forces that maintain order. At 94.97 grams per mole, this polyatomic structure dictates the boundary between cellular stability and systemic collapse. In the intensive care unit, a severely malnourished patient undergoes aggressive nutritional rehabilitation. The clinical team introduces a high carbohydrate load to reverse the effects of prolonged starvation. A stat electrolyte report triggers a panic alert. The patient's serum inorganic phosphorus has collapsed. Within minutes, cellular engines fail. Red blood cells lose structural integrity and burst in the bloodstream. Concurrently, the diaphragm loses contraction capacity, leading to respiratory failure and neuromuscular collapse. The standard clinical response is to execute an immediate, rapid intravenous phosphate correction to replace the measured deficit. A clinical pathologist pauses before authorizing this correction. The central question is diagnostic validity. Is this a true transcellular shift driven by refeeding syndrome, or are you looking at pseudo-hypophosphatemia, an analytical mirage induced by laboratory interference? Rushing a blind intravenous correction without verifying the laboratory data can be fatal. If the measured level is false, the excess phosphate will bind to ionized calcium, creating an uncontained crystal storm within the patient's vasculature. To understand this mineralizer, we must deconstruct its architecture. Orthophosphate consists of a central phosphorus atom covalently linked to 4 oxygen atoms in an sp3 hybridized tetrahedral layout. At physiological pH, 80% circulates as dibasic phosphate, while 20% exists in monobasic form. This structure allows for high-density energy storage. In the phosphoanhydride bonds of adenosine triphosphate, negatively charged oxygen centers repel each other, creating intense electrostatic tension. Phosphate resists spontaneous hydrolysis, but during specific enzymatic catalysis, the terminal bond cleaves, releasing massive free energy. This thermodynamic profile makes phosphate the primary chemical energy currency. It fuels cellular pumps and enzymatic cascades, while remaining independent of binding proteins like circulating immunoglobulins. In a 70-kilogram adult, the body holds roughly 800 grams of phosphorus. 85% is permanently logged within the skeletal matrix as hydroxyapatite crystals. Another 14% is sequestered inside the intracellular space, where it drives glycolysis and maintains the integrity of cell membranes. This leaves a highly vulnerable fraction. Less than 1% of the body's total phosphate circulates in the blood plasma and extracellular fluid. During refeeding syndrome, a sudden insulin surge forces glucose into starved cells, triggering an immediate, massive demand for phosphate to phosphorylate that glucose for metabolism. Billions of cells simultaneously consume their internal stores, rapidly pulling the remaining 1% of circulating phosphate out of the bloodstream to synthesize ATP. The biological economy operates on a razor-thin margin. Any sudden transcellular shift instantly bankrupts the circulating supply, crashing the systemic engine. The human framework defends this 1% margin through the kidney. The proximal convoluted tubule is the primary gatekeeper of the systemic phosphate pool. This tubule reabsorbs up to 85% of the filtered load. It utilizes specialized sodium phosphate cotransporters, NAP2A and NAP2C, to reclaim the mineral from the urine. When serum phosphate levels rise, osteocytes secrete FGF23, and the parathyroid glands release PTH. These hormones bind to receptors on the proximal tubule cells, triggering a signaling loop that instructs the cells to internalize and destroy their own transporters. Without these transporters, the phosphate has no mechanism for reabsorption. It flushes out of the body through the urine. Phosphate homeostasis is a highly active process. The body's hormone-driven destruction and recycling of its own infrastructure to maintain the necessary circulating concentration. The inverse risk is hyperphosphatemia, often resulting from renal failure in chronic kidney disease or massive cell death in crush injuries. When the kidneys cannot excrete the excess, the retained phosphate aggressively seeks ionized calcium in the bloodstream to form a partnership. This interaction is governed by the calcium-phosphate cross-product. Clinical data shows that blood plasma hit a thermodynamic saturation point at a value of 55. When the product exceeds 55, minerals crystallize out of the plasma, causing serum calcium levels to plummet, triggering muscle spasms and lethal cardiac arrhythmias. This precipitation leads to calciphylaxis. The crystals deposit into soft tissues and the endothelial lining, choking off blood flow to the skin and subcutaneous fat. Long-term exposure to excess phosphate alters genetic markers in the arteries. It forces vascular smooth muscle cells to undergo a phenotypic transition, reprogramming them into bone-forming cells. Surpassing the cross-product threshold instructs the cardiovascular system to actively synthesize bone matrix. Flexible blood vessels become rigid and ossify into stone. Physician decisions depend on the accuracy of that 1% circulating measurement. However, the pathology lab contains its own hidden booby traps. The standard measurement is the ammonium phosphomolybdate complex assay. The lab adds an acidic molybdate reagent to the serum, forming a complex. A spectrophotometer then fires an ultraviolet light beam at 340 nanometers. The intensity of the light that reaches the sensor determines the phosphate concentration. The first trap is ex vivo erythrocyte leakage. If blood sits in a collection tube for more than 2 hours, the cells exhaust their glucose and lose membrane stability. Their internal phosphates leak into the serum, creating a falsely elevated reading. The second trap is the paraprotein mirage, found in patients with multiple myeloma who have massive quantities of abnormal immunoglobulins. When the acidic reagent hits the patient's serum, these abnormal proteins instantly denature and precipitate, physically blocking the ultraviolet beam. The analyzer interprets this lack of light as an astronomically high phosphate level. It reports a critically high pseudo-hyperphosphatemia result that does not exist in the patient. Without a pathologist to recognize this optical illusion, clinical teams may initiate treatments that harm patients whose phosphate levels are actually normal. Safeguarding the laboratory from these mirages requires rigid statistical rigor. Analyzers are calibrated to primary reference materials, such as NIST SRM 909C, to maintain global precision. We utilize the reference change value to interpret serial results. Because phosphate levels fluctuate, a change must exceed 15% to be considered a genuine biological shift rather than random analytical noise. This threshold highlights a stewardship failure, ordering repetitive mineral panels on stable patients. Chasing minor fluctuations leads to redundant data and unnecessary clinical intervention. Precise stewardship requires monitoring phosphate only when clinically justified, such as during active intravenous replacement or acute metabolic shifts. Lock in the diagnostic axioms of human phosphate architecture. 1. The paraprotein enigma. Monoclonal immunoglobulins precipitate in acidic reagents, creating a false optical high. 2. The insulin and flux vector. Carbohydrates in a starved patient dry phosphate intracellularly, causing respiratory failure. 3. The diurnal metric. Serum phosphate peaks in the morning and troughs in the evening. Standardization to early morning fasts is essential. 4. The precipitation ceiling. A calcium phosphate cross-product above 55 triggers metastatic calcification. 5. The reference change threshold. A 15% variance is required to identify a genuine biological shift. Mastering this molecule requires managing boundaries from the hydroxyapatite bone crystal to the spectrophotometer cuvette. This concludes the phosphate installment of the Human Architecture series.